Hello, everyone. Hello. We're just going to give everyone about a minute to join the party before we kick off. I can see the number is rising, which is great. For anyone that's not done a Teams webinar before, it looks like you're going to appear on screen, but I promise you're not unless you're a speaker. So please do not be dissuaded. Do not leave. Just give it a minute more. Okay, great. I think we'll kick off. So hello, everyone, and welcome to our event, which we've titled, How Can Behavioural Science Help Improve Vaccination Uptake? Please feel free to introduce yourself and the organisation you're from using the chat function at the top of the screen. I feel like a flight attendant. Feel free to also ask questions throughout using the Q&A function if that works for you, conveniently also placed at the top of the screen. We can see all of our panellists on camera, so that's great. I'm Michaela. I'm a senior consultant, behavioural science lead and part-time webinar host. In terms of my vaccination credentials, I've worked on COVID-19 vaccination uptake at Claremont, and you'll see a small amount of that work today. I've also just had my flu vaccine, which I would highly recommend if you are looking for a shot in the arm. We've had over 120 registrations for today's event, a mix of NHS, public health, regional cancer alliances and councils, amongst others. So thank you so much for registering and for joining. We've got some really excellent participants in today's event. So we'll be hearing from, first of all, Faye Laker, who's the campaigns manager at the London Borough of Barking and Dagenham. Hello, Faye. I hope you're waving, but I actually can't see you on my screen. Faye will present some of our joint efforts to increase vaccination uptake in the borough, alongside Claremont's Ian Fannin. Hello, Ian. And Ian will also touch on some behavioural science models that are particularly relevant to this topic. And we also have a brilliant panel ready to go in about 25 minutes. And this includes James Hart, who is the Head of Operations for NHS Services at Vaccination UK. Hello, James, wherever you are on the screen. And also we've got Michelle Constable, who is a health psychologist by training and now Head of Behaviour Change Unit at Hertfordshire County Council. Hello, Michelle. Thank you very much for joining us. And finally, we've got the wonderful Riyadh Kareem, and I've been practicing this. Riyadh is the Assistant Director of Community Engagement and Vaccine Screening Equity, COVID-19 and Influenza Vaccination Programmes, at NHS England, specifically in the London region. You sound very busy, Riyadh. Hello to you, and thank you so much for joining. And we'll be discussing all things vaccination uptake today. Hesitance to receiving vaccines is obviously not new. While researching this topic, I learned that as early as the 1800s, there was skepticism about the newly discovered smallpox vaccine, and early misinformation included claims that the vaccine could turn people into cows, that it was an unnatural and ungodly interference with the body. So, the reasoning might have evolved, hopefully, but the need to kind of myth bust, to actively encourage people towards vaccination persists. So with that, we're going to get going. If our panelists could kindly go on mute and camera off. I think everyone's on mute. If you could turn your cameras off, please. Ian, if you could please unmute and hopefully share your slides. I'm going to hand over to you.
Okay, thanks, Michaela. Give me a moment. Okay, can everyone see that okay?
Yeah, looks good.
Okay, so thank you, and hello everyone. This is what we're going to try and cover in the next sort of 25-30 minutes. So I'll begin by defining the problem before discussing how behavioural science can help us understand barriers to vaccination and how we can overcome them. And I'll touch briefly on our reflections on recent national campaigns before Faye and I will tell you a little bit about Claremont's work in North East London. So let's start by defining the problem that we're here to discuss. So why are vaccination campaigns needed? Everyone attending today, I'm sure, will almost certainly know that routine vaccinations available on the NHS are designed to protect against a wide range of infectious diseases. Many of these are aimed at building immunity in children, including the MMR and 6-in-1 jabs, while some are also aimed at adults, including COVID and flu vaccines. But to be effective, they obviously rely on high uptake among the population. So, for example, for under 5s, the WHO target is for 95% to be vaccinated. And we all know that one of the reasons some people don't get vaccinated is due to active distrust in vaccines, which causes hesitancy. And this isn't a recent phenomenon, as Michaela suggested. So, the anti-vaccine movement began almost as soon as the very first vaccine for smallpox began being given to children routinely in the mid-19th century. And back then, the first vaccine, that vaccine was compulsory in the UK, and that was a big part of the problem. But this stopped in 1972, and the movement lost support. Then in 1998, everyone's familiar with the fact that the disgraced academic Andrew Wakefield came out with his fraudulent Lancet paper that falsely claimed a link between MMR and the MMR vaccine, and autism, and that caused a resurgence of that mistrust. And although that falsehood has been thoroughly debunked, it's caused lasting damage to this day. And it's clear we're now living through a new wave of vaccine hesitancy in the wake of the COVID-19 pandemic, fueled by misinformation that spreads through social media, frankly, as quickly and effectively as a virus spreads through a population. I don't especially want to dwell on disinformation and misinformation excessively today, but I do want to give you a sense of the scale of the problem. So this chart is a few years old, but it shows just how rapidly during the pandemic anti-vaccine social media accounts grew their followings on Facebook and Instagram. The Center for Countering Digital Hate in the US estimates that the top 147 anti-vaccine accounts increased their following by about 19% during 2019 and 20. And the biggest English language anti-vaccine accounts now enjoy a global following of almost 60 million people. So in spite of the growth of this movement, it's important to remember that the early COVID-19 vaccine rollout began strongly in the UK, with more than 90% of the population over the age of 12 vaccinated with at least one dose by January 2022. However, a University of Edinburgh study found that the proportion of people who were under-vaccinated by June 2022 ranged between a third and a half of the population. That varied quite a lot across different parts of the UK. The highest rates of under-vaccination were found in younger people, men, people in areas of higher deprivation, and people of non-white ethnicity, as these charts from ONS show. And although how much of that is driven by hesitance caused by lack of trust and misinformation, as opposed to just complacency and a lower sense of risk and urgency, is up for debate. What we do know is that this new wave of vaccine hesitancy doesn't appear limited to COVID. So uptake of childhood immunisations fell during the pandemic, and in 2022 to 23, MMR vaccine uptake fell to its lowest level since 2010-11. And cases of measles are rising. So according to data from the UK Health Security Agency, there were 1,603 suspected cases in England and Wales in 2023, compared with just 360 in 2021. And there have been localised outbreaks reported, including in London and the West Midlands. And this map from NHS Digital shows the most recent picture for the MMR1 vaccine. This is vaccine coverage at 24 months across England, and only the dark blue areas are meeting the WHO target, and the average is just under that target at 92.5%. For MMR2, which is given between 3 and 5 years old, this is even lower at around 85%. And the same problem is evident for the 6-in-1 jab, with a similar number, around 85% of coverage among under 5s across the UK. So in the face of this sort of unstoppable spread of misinformation via social media, it would be easy to get discouraged working in public health and believe there's little that you as a regional authority can do against this global problem. And indeed, there is this principle called Brandolini's law, which is otherwise known as the BS asymmetry principle, which holds that the effort and energy needed to refute misinformation is vastly disproportionate to that needed to produce it. So given the scale and ease at which anti-vaccine material is produced and shared, what hope is there of countering it? Well, it's undoubtedly a serious problem, but I think there is reason not to despair. For one thing, the vast majority are still getting themselves and their children vaccinated, and most still trust vaccines, as these charts from a recent study published in Nature Medicine show. On the right, This shows fewer than 9% in the UK are hesitant about the COVID-19 vaccine. This is from October 2023, while the chart on the left shows a majority, 56%, agreed that following the COVID pandemic, they were more willing to get vaccinated against other diseases, with 19% disagreeing. There are plenty of studies that have shown that for those who are hesitant, it is often just that, hesitance through uncertainty, and in many cases confusion caused by a swirl of conflicting sources. And there's a big difference between this and steadfast opposition. And I think there's lots that can be done to engage positively with people who are just unsure. And also, misinformation is only one of the reasons causing hesitancy. There are a lot of other things that authorities can do to increase uptake. So let's talk about how behavioural science can help to diagnose the full range of barriers to vaccination and to identify levers you can pull that can increase uptake. So Claremont did a literature review looking at this challenge through the lens of UCL's COM-B model of behaviour. And this shows that there are additional issues that organisations planning vaccination campaigns need to consider beyond addressing misinformation and distrust. So under capability, for example, it's important to recognise that some hesitancy is simply due to low health literacy and knowledge, or confusion caused by negative stories rather than resolute objection. And more specifically, with parents, a common problem can be that many don't know the correct vaccine schedule, so making this information more readily accessible can be important. Under opportunity, there are often practicality and logistical issues that, the fact that people need to take time off work, travel to a vaccine clinic that may not be nearby, or the availability of convenient appointments. And perception of ease here can be really important, but also social norms within communities or religious groups can be influential. So if people perceive the norm for people like them to be not to get vaccinated, that will fuel greater hesitancy. And under motivation, people can lack understanding of the risk of a particular disease. So emphasising the importance and urgency of vaccination is key. A useful alternative model for considering the psychological factors of vaccine hesitancy was designed by Cornelia Betsch and her colleagues at the University of Erfurt in Germany. Her team concluded that most factors could be grouped under confidence, complacency, calculation, constraints, and collective responsibility, and that most of the variants seen in vaccination uptake can be explained by people's different attitudes and beliefs towards those factors. And it's worth adding that the first of these three C's, confidence, complacency, and calculation, are especially affected by common psychological biases that we're all prone to. So negativity bias describes the tendency for negative information we hear to be highly salient and memorable, meaning stories about negative side effects of vaccines, even if those are rare, may carry undue influence and affect our confidence. Conversely, optimism bias means some will hold the belief that the disease is unlikely to seriously affect them, or that they're unlikely to get it at all, which can lead to complacency. And confirmation bias means that those who are predisposed to mistrust are more likely to search for and find information that confirms their doubts, meaning those who score highly on the calculation measure of the 5 C's are more likely to be vaccine hesitant. But what can behavioural science tell us about solutions? So we were especially impressed by a mega study that was conducted by Professor Katy Milkman and her colleagues at the University of Pennsylvania in 2021, which was a field experiment conducted with over 47,000 patients, which experimented with multiple different approaches to text message-based nudges to encourage people to attend flu vaccination appointments. The study showed that text message invitations and reminders can be highly effective at increasing uptake, and in particular showed that something called the endowment effect can be a powerful tool. So this effect describes the way we tend to value things more if we perceive they belong to us. So when reminder texts told people their vaccine was reserved for you or waiting for you, this encouraged higher uptake. And Professor Milkman's team went on to scale up this study in 2022 through a partnership with a large pharmacy chain in the US, enabling them to experiment with 7 different sets of behaviourally informed vaccine reminder messages sent to almost 3.7 million patients, as well as testing the effect of offering free round-trip taxi rides to their appointments. And this study reinforced the strongly strongly the power of reminder text. So particularly where default dates and times for appointments are set rather than leaving individuals to make their own appointments, which incidentally has been shown to be effective in cancer screening too. These on the right were the highest performing text reminders. So this showed that prompting people to plan the specific date and time and place of vaccination increased the effectiveness of reminders. But it was also effective to highlight the high current infection rates in their county and for the text to appear to be sent directly by the team at the patient's most visited pharmacy. Incidentally, the use of the free rides, they concluded in this study that was not effective. So Claremont's had a chance to, over the last couple of years, to apply some of these insights to our work, which we will come on to shortly. But I first wanted to briefly reflect on the range of approaches taken nationally in the UK in recent years. So there's been a plethora of recent national campaigns to increase childhood immunisation uptake. And we can see some evidence of behavioural science being applied in some of these examples. For example, this campaign is clearly attempting to address complacency, emphasising that measles cases are rising and giving striking stats underlining the importance of vaccination. But that's notably absent in most of these other approaches. The campaigns on the right have at least given a really clear onward journey, directing parents to their GP practice to book an appointment, which is something we noted was really missing from that left-hand campaign, and that therefore risks failing to make vaccination feel easy by not directing people on how to act. And this is the current flu and COVID vaccination campaign from the NHS, which first ran last year, and I've noticed that's out and about again now. And this encourages people to get winter strong. I'm always hesitant to criticise campaigns where I've not seen the underlying insight, but I must admit, from what I have seen of this, I'm a little sceptical about the effectiveness of it. I suspect it's coming from a place of insight that is trying to give individuals more agency, the sense that they can do something to combat these common diseases. But I think there's something in the execution, that quite playful execution. It's certainly eye-catching, but for me it risks seeming a little frivolous. I'm sure there is more depth to the messaging used in other communications channels that isn't seen in a poster or out of home ad. And as I say, I haven't seen the insight, but on the face of it, it's not clear to me what behavioural barriers that campaign is really addressing. And so overall, my sense is that the vaccination campaigns that have been conducted in the UK in recent years may be a little underpowered and could be more sophisticated if more insight from behavioural science was adopted. Which takes us to our recent work in North East London, and I'm going to hand over now briefly to Faye Laker, our client from Barking and Dagenham Council, to describe the job we needed to do. So Faye, can you come on camera and I'll keep driving the slides for you.
Lovely. Thank you very much, Ian. And thank you for inviting me along today to share the work that we've been doing with Claremont around vaccine uptake. And as Ian said, I've just got a couple of slides, and I'm just going to quickly sort of set the scene and kind of outline the challenge in Barking and Dagenham and why we commissioned Claremont to support us in driving uptake in the borough. So, next slide. Thank you, Ian. So the challenge for our borough, and there are often lots of challenges in Barking and Dagenham. So uptake of the COVID-19 vaccination was one of the lowest in London. And what we were finding were that residents were increasingly impacted by vaccine inequity, and had been very much disproportionately impacted by the pandemic. This is because, we are a borough with a very diverse population and very high levels of deprivation, low levels of health literacy. And we knew that actually just a kind of broad brush comms approach to increasing uptake of COVID-19 vaccinations wasn't going to work for our borough. What we needed was more of a kind of 360 social marketing approach, whereby we integrated quite an extensive programme of community engagement alongside targeted marketing activity. Because otherwise we were not going to be able to effectively engage with those people that are disproportionately impacted by COVID-19, and also address some of the quite significant local barriers to access. Next slide, please, Ian. Thank you. So why did we need the campaign? From looking at kind of local and national insights, we knew that one of the key barriers was around ease and convenience. We know that within some of our communities, there was a lot of vaccine hesitancy that actually was quite deep rooted and would be obviously more difficult to address. So we kind of wanted to look at those kind of low hanging fruits and kind of look at some of those barriers that we could more easily overcome. So within the borough, we had started to work on a programme of outreach with our health and community sector partners around kind of offering sort of more wider sort of health, place-based health access for our communities. And we sort of set up a series of what we called sort of GP pop-up clinics, and we found that they were really, really effective in helping to address some of those health inequalities in the borough. So we decided to actually try and take that approach to vaccine uptake and offer a series of pop-up COVID vaccine clinics. But obviously we needed to drive attendance to those clinics. So what we wanted to do is, so what we looked to do was commission a specialist behaviour change agency, Claremont, to help us in supporting that campaign and kind of really sort of helping us kind of hone that messaging and the tactics in order to kind of drive attendance to those clinics. So at the time, it was kind of post-pandemic, we knew that there was a lot of kind of COVID vaccine fatigue coupled with an increasingly low sense of urgency. So we were kind of in quite a difficult situation, and it wasn't going to be people's priority any longer to get their COVID-19 vaccine. So there was a huge challenge. So as I say, we needed a specialist behaviour change knowledge to help us really kind of hone that campaign and for the messaging to resonate and actually gain cut through with our residents. So I'm now going to hand you back to Ian, who is going to talk a little bit more about the campaign in more detail. Thank you.
Thanks, Faye. So yeah, our goal was to increase uptake of the booster. We wanted to make sure we maximised impact within the limited budget and the time constraints that we had. And so we agree with Faye and her team that we wanted to narrow the focus on those who had been previously vaccinated from the most deprived wards and ethnic minority groups who are eligible for the booster and not yet had it. Now, normally at Claremont, we do quite a bit of qual research to make sure we fully understood audience insights and barriers before we design a solution. In this case, there were time constraints, and that meant we relied mainly on secondary research insight. We did do a little primary research, including some focus groups and interviews at a local mosque. And from that, it was really obvious that reinforced what Faye has just said, that COVID didn't feel like a serious risk. Many had felt it had largely gone away. And as expected, we also heard trust issues raised and concerns about side effects. And also people specifically told us they wanted specific logistical information about the clinics and clarity that the vaccines are free. So this was our solution. We designed a very simple typographical campaign in the NHS style and colour palette, delivered through out-of-home posters and leaflets in pharmacies and on social media. And we deliberately went for a creative approach that was simple, bold and clear, rather than distracting with photography or illustration. And the design built on earlier work the council had done in a similar style, in particular using that warning stripe border to subtly signal to people that this was an urgent message demanding alertness. And the messaging was focused on the ongoing presence and risk of COVID right now in Barking and Dagenham, clarifying who's eligible, ease and convenience and the fact it's free, and driving to pharmacy walk-ins and pop-up clinics. And we added specificity around the fact that cases were increasing locally, as well as around eligibility and locations of vaccination clinics. And importantly, we also employed the endowment effect, which is highlighted on this slide in the red circles, with the use of the words "waiting for you" in the headline and in that sign-off text. But arguably the most important thing we did was work with the Barking and Dagenham public health team to use the endowment effect in text message reminders sent via GPs. So this was an example of a text aimed at people who were eligible because of pregnancy. And there were a series of tailored messages personalised to the eligibility of each individual according to the NHS data held about them. And you can see here we used in that reminder the message, remember your free COVID booster vaccination is waiting for you. And the results were really good. We helped ensure 1,134 vaccinations were administered at 37 pop-up clinics over the time of the campaign. And the clinics that were promoted using text message reminders drove almost 6 times the number of attendees. So that was the COVID work. I'm also going to very quickly touch on the fact that because that went so well, we then worked with Dagenham in a very intense way over a few weeks to rapidly apply similar insight to help uplift MMR vaccinations in the borough. Again, there were significant time pressures, so our strategy really was to apply the similar thinking from the evidence we had from secondary research and from the campaign we'd just done. So focusing on driving salience with the message about cases rising and specificity around eligibility and clinic locations. And given this was a childhood vaccination campaign, we wanted to warm up the creative a little bit in this one as well, so avoid being unduly alarmist. So while still driving urgency with that headline message. And the use of illustration and a softer colour palette in this instance helped with that, as did highlighting the free family activities that were on offer at the clinic. We helped get the messaging right as well in a letter that was sent from the Director of Public Health to 60 schools in the borough to promote the clinic. And again, here, text messages were sent to 19,000 children's parents of children aged 4 to 16 with incomplete MMR status. And again, we used the endowment effect, as you can see here. And this campaign was just as effective as the COVID one, with hundreds of children vaccinated across the borough. We're told we even broke the London record for the February half-term clinic with 183 vaccinations in one day, and most of this attendance driven by those text reminders. It is worth noting, though, we understand that when only one text message was sent rather than two, with that important reminder, that clinic attendance did appear to be lower. And I know that Dagenham have been sort of looking into that further and experimenting a bit more to understand the added impact of sending 2 text messages. So this is the final slide. So across both of these campaigns, I think there were a handful of key ingredients for success. A bold and importantly clear, creative, with urgency, specificity, and localization embedded in the messaging. The strong use of text message reminders using that endowment effect that we saw from the mega studies in the US. But also, we can't overlook that the locations of pop-up clinics had to be well chosen, embedded in those communities that matched the target demographic. And I think that's where effective partnership working between the NHS and public health teams was really key. And I think, Faye, you might wish to finish by saying a little bit more about that and the role that had to play in the campaign.
Yes, thank you, Ian. So absolutely. I mean, this campaign, our vaccine uptake campaigns have been held up, certainly with MMR, have been held up as best practice. And we kind of describe it as a perfect storm, really. As you say, it's about that combination of ingredients. But I guess for me, it really is the kind of collaboration and that kind of partnership working with our health partners and also our community and voluntary sector partners, and us kind of, being able to kind of leverage their relationship and their influence with some of those certainly hard to reach communities. And then, sort of working in partnership with and bringing Claremont in to support us in terms of their expertise around, behavioural science, and really, really helping to kind of tailor the messaging and creative approach so it really gained that cut through, I think was effective. And then having that very tangible call to action, which overcame that barrier around ease and convenience, and those, as you say, those very targeted pop-up vaccine clinics in our area, in very specific areas where we knew people were relatively kind of disengaged with other kind of primary health primary care, sorry, where they would normally get their vaccine. So as I say, it really was the kind of perfect storm, and very much down to that kind of collaborative partnership approach, which we are now applying to kind of more of our work around public health.
Thanks, Faye. Back to you then, Michaela.
Thank you so much, Faye. And I'm going to come back to that partnerships piece in the panel. It's really interesting. And I had the privilege of working on some of the very early part of that campaign, and I think it's impossible to predict what people are going to say, what barriers they face until you're really in those community settings, kind of talking to people privately. And I'd like to welcome our panel back now. So panel, if you could please turn on your camera and go off mute. Jenny's going to attempt to do some fancy spotlighting things, so hopefully we appear more clearly for everyone. And I'm going to start just by asking everyone to introduce themselves very briefly because of time, just talk about your experience in this space, and then any reflections that you might have on Ian and Faye's presentation. James, I'm going to start with you, who's been spotlighted just in time.
Good morning, everyone. It's really lovely to be here, and it was really insightful and a really interesting presentation. So thank you, Ian and Faye. Some faces I recognise in the attendees list as well. So good to see you and meet some new people as well. So I'm James Hart. I'm the head of operations for Vaccination UK, and we're responsible for delivering school-age vaccination services across North London and also several other geographies in the UK, up in Yorkshire and the Humber, the West Midlands, and also Hertfordshire and East Anglia. And we deliver services to sort of 0 to 19. So it's our flu, diphtheria, tetanus, polio, meningitis, HPV, and also neonatal Hep B and BCG services. So we deliver a fairly broad spectrum of services in the sort of 0 to 19 space. And interestingly, watching that presentation, when you're talking about those MMR clinics, I recognise that photo because that was some of our team there delivering those vaccinations. So we kind of very much witnessed the effectiveness of those text message campaigns, so it's really good to hear some of the narrative behind the work you've been doing. And I think one of the big changes that we have noticed is you're having to do a lot more work to get those vaccinations, and it's this kind of innovation and this learning that's really useful. And because the landscape has changed post-COVID, with uptakes being more challenged, you have to put more effort in. When you're talking about Brandelin's law, that was really interesting, and I think that's definitely something we need to look at.
Brilliant. Thank you, James. Thank you so much for joining. It's really good to have you. Michelle, I'll come to you. If you could do, please, very brief intro and any reflections you have.
Good morning, everyone. Yeah, I'm Michelle Constable. I'm the head of the Behavioural Change Unit at Hertfordshire County Council. We've done a lot of work around the COVID vaccine and more recently now the booster vaccine, looking more specifically at immunosuppressed patients. Lots and lots of fantastic behavioural science in there. So it's really wonderful to see that. It's so important to have that insight before developing the messaging is one of, I think, the key messages from that. And I can see there's lots of useful stuff to share there. Really wonderful. Thank you.
Brilliant. Thank you so much, Michelle. And Riyad, I'll come to you, please, if you don't mind doing a quick intro, any reflections you have.
Hi, thanks. I'm Riyad. I'm Assistant Director for Community Engagement and Vaccine and Screening Equity for NHS England London. Yeah, really helpful, great insights there. And, it's so important to, particularly, it all was summed up in your last slide about the ingredients for success. Really helpful, lots of takeaways for all of us actually on the call. And it kind of reinforces the need for us to work in, real partnership with the communities, trying to understand our communities more in a much more holistic way, and recognizing, I think it's really important to recognize that vaccinations and screening is part of a wider health conversation that we need to have with our communities, where they understand that they have agency, and where we can, as a system at people, place and system and region level, can definitely address the gap. Not only just for health inequalities, but also between us and the communities that we need to serve so desperately. So I think that's really important. And then in my particular role, it's all about basically addressing that gap and how we can improve vaccine equity across London by understanding our communities more and actually bringing the system closer to those communities. So we're trying to do that in terms of building trust and confidence, particularly for low uptake communities in London, underserved communities, by bringing the VCSE sector, public health, NHS partners, the local authorities, closely together at place, system, region level through the vaccination and screening groups that we've been convening across our communities. And we followed a community-centered approach because we all know that one size doesn't fit all. And it's I think it's just a combination of all the above and what we need to do together as a system. We have Somali communities right across London, not just in one borough. We have Bangladeshi communities across London, Pakistani, Black African, Black Caribbean, Eastern European. We need to disaggregate. We need to go deeper and understand the nuances of how to engage with the Romanian community vis-a-vis Bulgarian, Lithuanian. So, you know, the list is endless. The task is so much, but actually, if we do it smarter, we will be able to reach those communities. It's not that communities are hard to reach. We need to reach them in a way which is smart and brings real traction and resonates with them.
Thank you, Ria. That's really well expressed. I've actually got a question about underserved communities, which I hope that we'll have time to get back to. You kind of expressed, you know, is it possible to use vaccine research more broadly in public health? And we've had a good question come in for Ian and Faye that kind of touches on that. So this is from Raj Lakshman in the chat. So he kind of says, have methods that you've outlined that have been effective for vaccines, have they been used in other health issues like obesity, mental health? Do you think the things you've outlined could be used when thinking about, you know, obesity campaigns or mental health campaigns?
Do you want me to go first on that, or do you want to go,
Yeah.
Faye?
You go in, then I'll follow.
I mean, Claremont hasn't specifically used those. If we're referring to, for example, the endowment effect, we haven't specifically used that on obesity campaigns or mental health campaigns ourselves. Obviously, the techniques that we've talked about can be used. So the use of that COM-B diagnosis is something we do very commonly across lots of our work. Sometimes we'll use different diagnostic frameworks, but the important thing is to really try and understand for that particular context, for that particular audience group that you're trying to target, and for the type of behavior, the target behavior that you're trying to change, really examining what the evidence shows from secondary research, from literature, but also from getting in amongst communities and speaking to people. What are the insights that are most important? So that's where we would always start. That might then lead you to conclude that some of the techniques that we've applied in this case are important. Often things like specificity. We often say that specificity dissolves resistance, and often campaigns can be too broad, too vague, not feel directly relevant to an individual. So that personalization, that specificity is regularly important, as is a sense of some degree of urgency that you need to act on this now in order to compete with the other demands that someone has for their time. So there's many things that we'll read across, but I would encourage people always to go back to the context and examine the insight for that particular thing, rather than just copying and pasting across to a different issue.
Yeah, that's very good advice. Faye, do you agree with that? You can disagree if you want. It'd be difficult. Yeah.
No, absolutely. And as you say, I think on actually obesity is one of the areas that focus areas for Barking and Dagenham sort of going forward. And I know that I've got some public health colleagues also on this call. So yeah, they're obviously aware of that work. So yeah, absolutely. I mean, I think it's a very individual issue, and there's very kind of specific, people have very specific attitudes and beliefs around that area. So, you know, it absolutely has to be very kind of targeted activity. And then I kind of go back, I think for me, I would go back to the kind of the sort of partnership working and collaborative approach. And it's about reaching those, I guess it's about reaching those individuals and kind of like cross referral. So for example, you know, we might be aware of, somebody might present themselves to the local authority who has social care issues, maybe issues around, I don't know, sort of isolation or something, you know, is suffering with stress because of like other issues, financial issues, whatever issues, housing issues, etc. And it's about us kind of getting to the root cause of that and looking at kind of other issues that that person has, and then working and sharing that knowledge with our health colleagues, because it might be that we refer someone to a health practitioner, and then they pick up, okay, well, actually, you know, you've got underlying diabetes and that's making you feel really unwell. But so again, it's about that kind of sharing of information and working in partnership to kind of cross refer.
That makes total sense to me. Someone's written in the chat that we need to be preventative, not reactive, which I think is the real point, but brings me on to my question about limited budgets and how that can be quite difficult to be preventative. Faye and Michelle, I'm going to ask you, what are your kind of tips and tricks for working with a limited budget? I think a lot of people attending this event will probably be facing that challenge, how to use resources more efficiently. I don't know, Michelle, if you want to start, that'd be great.
Thanks, Michaela. Yeah, I think working as a system is really, really important. We all have limited budgets, and increasingly there are more and more pressures upon them to deliver. So I think understanding where there's a shared agenda and identifying perhaps key target groups that you have particular concern about, building on things like if there are national campaigns or national comms going out, say for instance about the COVID vaccine or the flu vaccine, but then looking locally about actually what are the key issues for your area, taking the time really understanding the problem you're trying to solve, because otherwise you can end up putting your resources in the wrong place. It's very easy to make assumptions about the influences between different groups on behaviour and influencers. So not just the message, but the messenger that we're using to actually communicate with people. So I think it's about targeting the resources in the right places and really understanding that problem. But also, I mean, some of the behavioural science work doesn't have to be massively expensive. Nudging in terms of text messaging and things like that, they're very low cost, but very effective. So if you have an understanding of the problem and you can write the comms in the right way, and then you can share them with those particular groups, you'll have a much more tailored and targeted approach. It's more likely to be successful.
Thank you, Michelle. We actually had a few questions about text messages in the chat. So I might ask you, a few people have asked, do you think text messages are the most effective way to reach people? Do we know about printed materials versus text messages? Which would you use? Do you have a view on that? It sounds like you've done work with text. Is there anything else that you'd recommend?
I think text messages, if they're coming from a trusted source, like a GP surgery, are very effective. So again, we're coming back to where the message is coming from. But I also think it depends on who your target group is. And if you have a target group who are digitally excluded, or they don't have access to digital, then obviously text messaging may not work. And so there might be other methods that you need to think about. And it may not be printed materials. It may be actually that direct contact from other professionals may be more directly helpful. We found this with pregnant women, young pregnant women, particularly in other areas such as smoking cessation, where we found that their lives may sometimes be quite chaotic, and therefore they didn't always have access to digital. And I just think we have to think about these nuances, because if you don't understand the target group, then you could miss some really key groups of people.
Yeah, I completely understand that. I think we're dancing around these audience groups, and I am going to come back to that because I feel like everybody's got a lot to say there. Thank you, Michelle. And Faye, do you have anything to add on kind of working efficiently with smaller budgets?
Well, firstly, just to kind of talk about text messaging. So for us, we have found that, and as you say, Michelle, it does have to come from a reliable source. So, you know, for example, around vaccine uptake from GPs, it has been the most effective channel for us in terms of driving attendance at our pop-up clinics. In fact, we did some A/B testing a few weeks ago, whereby we didn't do any other comms but text messaging. Again, it was targeted text messaging, again, working with the GP Federation, so, you know, by GP surgeries, and attendance was still high. So for us, it has been probably the most effective channel. I mean, for MMR, we found that actually the combination of using those kind of two sort of very influential sources in a parent's life, schools and GPs, by sending a text message from GP surgery coupled with a letter from the school, that was a highly effective combination. But yeah, just in terms of limited resources, as a local authority, obviously with diminishing resources, yeah, I absolutely agree with Michelle's point around just really ensuring that you're using insight to channel and target those resources in the most effective way. So we're doing less and less kind of broad brush comms now, and much more targeted activity, very much informed by insights from the partnership. So yeah.
Brilliant, thank you, Faye. And James and Rhian, I'm going to bring you in and start with James. I think partnerships can be obviously a very efficient way, can be a very efficient channel in order to reach people. And I'd like to ask you about your experience with partnerships. Do you have positive experiences? Do you think partnerships can be kind of an efficient and effective way to increase uptake? Are there any watch outs for you? James, I'll come to you. I know you've done a bit of work here.
Absolutely. I mean, partnerships are fundamental in what we do, and I think that's one of the biggest changes. If there's ever a benefit to COVID, that was it, that the increased level of kind of collaborative working. We're having this webinar over Teams. Up until 2020, people weren't using Teams, but now we all do. Gone are the days of face to face. It's a novelty when we sit in a room face to face, but that technology has allowed us to have these meetings and meet with diverse groups and share ideas, and it's had a profound effect on the way we deliver our services, and I'm sure everyone on the call will have a similar experience. Working in isolation, you may think that you're doing the best job for your communities, but you don't know. You can't be an expert on every demographic within the space you're working. So those collaborations are fundamentally important to make sure the message you're sending out is appropriate and correct, and is going to get the best kind of impact. That you are targeting or aware of these sort of underserved communities, because again, there are pockets of communities that perhaps you're not aware of, and you don't have the inroads to engage with those communities. So speaking to local experts, speaking with trusted leaders, and kind of upskilling those voices again has a profound impact on the way groups will engage with your service. So I can recommend it more highly, and I think it is fundamental. As a service provider, you need to go out and seek assistance to find out who are those underserved groups, or the communities at large. Who are the people that you are trying to reach, and what is the best way of reaching them? And have that sharing of ideas to make sure that your service is continually improving and learning from past mistakes and also past successes.
Brilliant, thank you, James. If only you could deliver vaccinations that actually would be winning, that'd be great. Rhian, I'm going to come to you and ask the same question. Have you got experience with partnerships? Is that something that's worked for you at the NHS in London? Oh, I think you're on mute, Rhian, sorry.
Yeah, we've done that. I've done that. Sorry about that. Yeah, absolutely. Partnership working is essential. I can't think of any other way where we can do this collaborative work together. Because it's all about building trust with the communities. It's all about understanding those nuances that Michelle mentioned. So I mean, I remember, during COVID, as James was saying, that was like, it was a given, wasn't it? We saw so many pop-up clinics, so much activity to get closer to the faith and community leaders, the women's leaders, the people who people look up to in respective communities. And then we saw that kind of gap being reduced between the statutory sector and communities, in terms of us understanding them and we understanding our communities in a much more better way. And I think that was because, as we say in Yorkshire, the proof of the pudding's in the eating. When you get involved in a project, and you bring all the stakeholders together, you get much more better product. And so we need to continue that momentum for community engagement. It cannot be just an afterthought to add on at the end of a project. Oh, let's go and consult the community. It's got to be the thought that is intrinsic, extrinsic, all the way through the continuum. If we're going to get real traction with the communities, we need to understand what are the kind of things in the recipe that's going to inculcate trust, and partnership working is essential to that. Absolutely.
Brilliant, thank you, Rhian. I'm going to come on to kind of different types of partnerships. And Faye and Michelle, I'm going to come back to you. A few people in the chat are talking about how there's a kind of a broken link with GPs in some boroughs at the moment. So I kind of wanted to ask, do you think sort of public health teams like yourselves, ICB teams, can work with GPs and pharmacists? Can that be effective? Can they be good campaign partners? And what might the watch outs be there? I don't think we've got any GPs or pharmacists on the call, but we might do, so watch out for that as well. And Michelle, I'll start with you.
I think GPs and pharmacies are essential. When people think about going and getting information or the vaccine, they're not thinking I'm going to go and find the council website. Unfortunately, it's generally they are thinking about the NHS and our community partners within that. We have really good relationships with our GPs and pharmacists. The work we just conducted recently around the immunosuppressed patients and the COVID booster vaccine uptake, we delivered through GPs. I think early engagement really, really important. And I think we also have to understand that there are resource issues. GPs and pharmacies are hugely busy and under a lot of pressure. So we need to engage early and engage well and actually have a clear plan of action of what those comms and messaging will be, because we all need to be delivering the same message in order to engage. But it's fantastic in terms of they are such trusted partners, and particularly pharmacists have slightly different relationships with their patients. They know them on a really personal level. They're coming in regularly and everything else. So I think there's a lot to be gained in terms of watch out. I think it's about making sure that we're working across the piece and that we're not inadvertently widening any health inequalities, that we're still looking at those hard to reach groups and deprived areas and making sure that messaging and approach is consistent.
Brilliant, thank you. And Faye, same question to you. Have you worked successfully with GPs and pharmacists? Can it be done?
Yeah, I mean, so as I kind of sort of set out, we have a challenge embarking in Dagenham in that, we are a hugely diverse borough and sort of health literacy in our borough tends to be quite low, and there tends to be quite high levels of disengagement with kind of primary care GP surgeries. So we, as a partnership, so, the local authority and public health, as I kind of mentioned earlier, we had been working together on a series of kind of pop-up GP health pop-up clinics. So it's about that kind of place-based offer in those areas, Michelle, as you say, which tend to be sort of underserved. And it's about us sort of proactively going into those communities and kind of reaching them in other ways. So it's not necessarily that someone would need to register for a GP, so to register to see their GP. They could actually attend that event, and then they can talk to a number of sort of clinical practitioners about a number of health issues, and then kind of register and kind of reconnect with primary care at that stage. And we've seen huge attendance at those events that have been really, really effective. So and again, that's all sort of part of our partnership working approach.
Brilliant, thank you. I think everybody's mentioned underserved audiences now, so I do want to come on to that. I think that's interesting. Sometimes they're called hard to reach audiences, but we did a whole event on that topic and we don't love that term. And we think the onus is really on us to reach those underserved audiences. Ian and I could talk about this for about 10 years, so I'm going to come to Riyadh and James in the interest of time. Riyadh, I presume in London, this is a particular issue because there's a lot of diversity. So kind of what work have you done with underserved audiences? How have you worked to reach them?
Yeah, this is a really important thing. How do we reach them and how do we improve the kind of take up of the vaccines? But it has to be located in that wider holistic health engagement. How can we kind of bring that closeness to the community between our and build the trust and confidence. So what I've been obviously my role is to give support, advice and guidance across the systems, across my ICB colleagues and local authorities, and also what I've been looking at recently is over the last few months I've convened a series of vaccination and screening groups. Because it's quite clear based on experience thus far with all of us in the call that one size doesn't fit all. So, and that's not going to be a recipe for delivering for underserved. To get them served, We need to understand the community dynamics. What are the things? What's in that recipe that we need that's going to be specific? And in London, I feel with the level of diversity that we have, that breadth and depth, we can actually do things once over for particular communities. But unfortunately, I don't know, fortunately or fortunately, we are working like, say, 32 boroughs, or how many boroughs that we have in London. What we need to do is think about London-wide approaches, community by community. And that's what the vaccination screening groups are doing to help build that trust, by bringing VCSE, public health, local government together to bridge that people, place, system, regional divide. Say, for example, recently we had the first ever London Bangladeshi Health Inequality Summit. We've got 322,000 Bangladeshis in London, the worst ethnic when you look at ethnic populations living in the most deprived areas and the highest levels of health inequalities. So but then, we need to be thinking, who are the trusted leaders in the Bangladeshi community, faith community, clinical, what are the trusted places? Is it places like, say, for example, East London Mosque, Ocean Women's Group, et cetera, et cetera. What are the trusted channels? We recently did a talk show that was had wide reception across London and national on Bangla TV, Channel STV, to talk about vaccinations with Bart's and other colleagues. So it's that kind of recognition that you've got to go deeper and understand who are the trusted leaders, trusted places, trusted voices per community. We can do that if there's appetite, that we can do that, and that's why I really encourage people to join our VSGs for Bangladeshi communities, Somali, Pakistani, Eastern European, really, and Black African Caribbean. Really nice, just to kind of add today that in this call there's so many good, excellent colleagues, and I've got 3 of the chairs of the vaccination group on the call. Got Galina from Barking and Dagenham, who chairs the Eastern European London VSG, because the great work that she and colleagues are doing with the VCSE sector, bridging that gap with health and local government partners, is now being kind of dispersed across London. Similarly, for example, with Black African, Black Caribbean, I have Toyinola Adams, who works for NHSE London and is the co-chair of the Black African Caribbean VSG. Her, alongside Pastor Nick Chanda from Enfield, who's part of the Redeemer Church, they're working right across London, trying to engage our Black African Caribbean communities and understand those particular nuances. And also, given the importance of faith, we also have a Black Christian and Black Muslim subsections to ensure that we don't leave any communities behind. And we appreciate in London that duality between faith and ethnicity and cultural. So it's really, really important. And also we've got Gabriela from Brent, and Gabriela and Mariana, they head up a Brazilian and Portuguese vaccination steering group. So this is actually a bit of a movement. We're not funded. In terms of vaccine equity, that's my role. But in terms of the vaccination effort, that is goodwill. That is the system coming together to support the communities. What better way to support Bangladeshis on vaccination uptake by actually improving our relationship on their health agenda, which is diabetes. And that's what we did. In Tower Hamlets on September the 24th, we did a whole summit on diabetes and pregnancy. Vaccination was there, so was breast cancer screening, but there was emphasis on the things that the community wanted to hear. But by gosh, if you go back to the community, they will be receptive now to talk more about vaccinations. But it's a tough gig, we all know that, but it's about building the trust. Make sure we keep the doors open to our community leaders. Sorry.
No, it's fine. Thank you.
I know you want to finish, Michaela, because we're running out of time, but really quickly on that, I think the key thing for me is dialogue, not broadcast. It's equipping those trusted leaders to be able to have those conversations when you're not in the room, and what tools, what resources, what skills can you give them to be able to do that well.
Yeah, for sure. And that kind of blending of socioeconomics, ethnicity, religion, when we're talking about underserved, we're talking about things that kind of live in the vein of all of these. And James, I'm going to give you the last word on this kind of work you've done with underserved audiences and maybe around system design and how you design the service to accommodate for those people. So I'm very sorry, you've only got a minute, but I would like to hear from you.
That's absolutely fine. I mean, I think for us, it comes down to access and information. And Riyadh has talked extensively about access. So perhaps I'll talk more about the information side of things. So for us, it's very much having conversations with the people that need to make these decisions. And there was a question in the chat about HPV, whether that has been affected recently, and it has. We've seen uptake rates drop since COVID, so we're kind of working to build that back. So what we're doing is speaking to young people who have a voice in their own healthcare. You know, we assume, well, parents need to make the consent decision for these young people, but of course they don't. But we encourage children to have conversations with their parents. So if we go into schools, have meaningful conversations about their own health outcomes and the interventions available to them, then hopefully they can make their own decisions, but they can also help kind of influence their parents in decisions they might make regarding vaccinations as well.
That's brilliant. Thank you, James. And I just want to thank all of our panelists and presenters. It's been a really interesting session. My main takeout is that it's a really hard job, but I feel more confident if I had a vaccination challenge. I'd feel more confident tackling it as a result of this. So thank you. We've had some really positive comments in the chat. Thank you to the audience for staying tuned. If you'd like to hear more about our events, we've mentioned a few things in the chat. You can follow us on LinkedIn. We've got a newsletter. We're also available on email if you've got any follow-up questions for the speakers or you've got your own vaccination challenge. And that's hello@claremontcoms.com. That's hello@claremontcoms.com. So I'll let everyone go now. Thank you so much to our panelists and to our audience, most of which have actually stayed with us to the end, which is brilliant, shows how good quality this was. So thank you. I'll sign off there and have a really good rest of your day.
Thanks, everyone.
Take care. Bye.
Bye-bye.